Good evening, everyone. I mean, we've had so many stalwarts here in the room tell us so much about healthcare, the critical care that we require, and I think Dr. Rajesh would like to shed more light on what we're discussing today with all of these stalwarts here in the room.
So they are going to have stories, and why I am going to tell stories? Because since long it is said that world is changing, and change is the only thing which is consistent. That's not correct. In fact, there are certain things which never change, and one among them is storytelling. So I'm going to take you for the stories which our panelists will ask. So this case starts when I was working as a resident in one of the very well-known hospital. One day in ward, our nurse goes for the round, and she finds that there is a patient whom she has left in the middle of the night healthy. He is dead and non-responsive. Blue code was called, but patient was stiff and non-responsive. There was a lot of noise because patient was definitely in paid VIP. Story starts that this patient has underwent angioplasty 48 hours before, shifted from ICU in stable condition, has eaten dinner, slept well, and did not wake up. In between what happens for 6 hours, nobody knows. So my question is with distinguished panel is this: is this type of event common, and can we prevent this kind of event, and if yes, how?
So obviously this patient has coronary artery disease, and I don't know whether he has multivessel disease and whether there has been a culprit lesion which has been tackled and other lesions which are still kind of, active, or could there have been a problem with the stent itself? Because, that is, though rare, it's possible. And obviously this kind of sudden cardiac death, it looks like a sudden cardiac death occurring in this patient. Yes, it would have been very much more advantageous to have had some kind of cardiac monitoring in the room that the patient was transferred to, because there's been a recent procedure and there could be underlying further vessel issues which have not been addressed. And, a basic monitoring at least of the cardiac rhythm and of the blood pressure, and some kind of warning system being set off if there was to be a perturbation in the same.
If you look at the hospital issues, the patient had angioplasty, and very rightly so. After 48 hours shifted, that's the time of monitoring that we normally do it, and he would have been ready to go by the next day. But something happened after the dinner, and by the time the nurse saw him in the morning, he was already stiff, so he was already dead for some hours. So he could have had a rhythm disturbance. He could have had a stent blockage or something for which could not be recognized because there was nothing to monitor him. So what was important for such a patient, who was a high-risk patient, even though had been fixed, but he could turn unstable, so he needed to be surely out of the ICU but monitored somewhere with some things which could be detected and acted upon early.
So let's not get into why this happened. I mean, there can be a lot of reasons this can happen, and we are not discussing differential diagnosis
of course.
here. What
Very
is
clear.
important here is very likely there were some warning signs which were not seen.
Yeah.
Most of the hospitals on the floor have one nurse looking after 6 to 8 beds. So that means they will have a fixed schedule where they will check the BP, pulse, and record it. In between, nothing happens.
Yes.
Unless there is a family attendant who is watching, or if he's also sleeping, they'll miss all that.
Exactly.
So it is this is what brings into the thing that most of the events, sudden cardiac deaths, are not really sudden. There are some warning signs which could have been caught earlier. In any of the vital parameters which you can be recording, which is primarily heart rate, blood pressure, respiratory rate, and maybe saturation. These are the only 4 important things which you will look at. So if something was probably caught earlier, but the most important thing I repeatedly want to emphasize here is monitoring is not curative. So one has to act on certain algorithms, certain SOPs have to be there, somebody has to be watching it and act accordingly. Only then you will be able to save lives, not but just by monitoring.
So if you have to monitor this kind of patient, normally it's not a routine practice. One patient is stable, gone in room, he doesn't have any symptom, nobody wants to monitor. Even he is in high risk, maybe a lot of borderline high risk patient, we think, okay, if he has symptom, we will see. That's what the kind of attitude in general we have. Suppose you are working in the best hospital of the country, and you want, okay, going in room, you want to monitor. How will you monitor this patient? You are having option. You don't have option of not monitoring. You have to monitor this patient.
Monitoring such a patient is not difficult, but who's going to see what is happening on the monitor?
Exactly, sir.
You know, the people will say shift to the ward and we'll have a monitor, and we'll keep a home care nurse, but she cannot realize the importance what is happening, and that is the problem. Somebody more experienced, knowing more, and as you said, algorithm, warning signs, and interpret and then act on that. You know, all these devices we've been hearing, they look very nice, but somebody observing and reacting to that, I feel, is much more important, because the way they are, I'm sure in next 5-7 years we'll have very good versions of these devices. But how to act, how to, you know, now you have less number of patients being monitored. Dr. Ravi Mahajan showed, suppose you are monitoring 1500 beds, and there is one command center. If there are 50 patients who are getting sick, how are you going to act on that?
I will answer that.
Yes.
So Dr. Diwan has given us solution before the problem, but I wanted to Dr. Chawla to discuss one of the problem is who is monitoring the patient if when you put the patient on monitor. What other problem you can have the traditional, whatever ward ICU monitor we put the patient on, what are the other problem this patient can have apart from who is monitoring or who is seeing this patient? What are the other things this monitor has problem?
You know, I think the answer to this is, your question is contactless monitoring, and somebody more experienced monitoring these systems.
Okay.
I think that would be the way forward for these patients.
See, there is
Kapil, you want to add something?
See, basically, I had two queries for this patient and kind of a monitoring. Suppose I put this patient in a room on a multi-para monitor. That's going to create two issues for me. One is the cost that patient has to bear. Second is the patient, what he feels about, like he's been told his blast is done, how psychologically he's also feeling that he's being monitored still 48 hours. Am I right? Whether something wrong is happening to me? This also makes a very important sense. So probably when we are monitoring this patient, his psyche also needs to be considered, and if we have something which is going to sort these two issues, will be more beneficial to this patient, because we will have better monitoring also.
Thank you. So basically what I want, Dr. Chawla sir, I'll come to you. Basically what I wanted to highlight, when we put the ICU monitor on bedside in room, one, who is monitoring we don't know. Second, it put additional cost to the patient. Third, disturbance to the patient, which is more alarming. Continuous alarm may be ringing. Your patient may not be able to sleep. And important thing, every 15 and 20 minutes somebody blood pressure being monitored in the room and nobody watching to them is a nightmare. So these are all some of the limitation of existing contact blood pressure monitoring which we have to keep in mind. So I'm not giving you a solution. We have a continuous monitoring system, but we have to look something which doesn't touch the patient, which can give us the accurate data if possible, and which can be cost effective as well as somebody monitoring to that. Most important is, as Dr. Mahajan emphasized, that somebody should be there to monitor. It should not be like, I have put the monitor and feeling safe. Okay, monitor is monitoring, but who is monitoring monitor and who is going to take action is the most important.
I just have a quick question here.
Yeah.
For the sake of being the devil's advocate, how much can we rely on monitoring devices? Like, when do we like shift the blame, or somebody takes an onus within the care system? Because in this case, it's a 20-year-old. Maybe there wasn't enough care available. So where is that conundrum? Like, where do we stand on that?
See, there is no question that a person who's after a short anesthetic is shifted to the room after, say, 4, 5, 6 hours, 20 hours later he has crashed. Yeah. Nobody can be being a continuous monitor with a nurse on the bedside. You cannot have that. So this is where these sort of things come in. The conundrum is ultimately a human mind has to check for what the thing is. Right. But that's where the technology comes in. You should have minimal false positives. That means you should not be giving false alarms. Patient sneezes, or he turns his side and it starts alarming and everybody freaks out. So that has to be obviously.
But do we need technology intervention at an earlier stage then, are you saying? That something like this can be avoided altogether?
See, with the AI technology coming in, these sort of artifacts, false artifacts, can be removed, by and large. And I think we have pretty good IT guys who are working on this, and we have a huge country. A problem of this is everyday problem. I mean, nursing shortage, deficiency of trained nurses, doctors, the numbers are going down per patient care, the quality of, I mean, probably being recorded, but I mean, we have to be very, very careful about the care which we provide.
Right.
So I think this is where these things come into play. I mean, in a huge country like India, AI technology and minimally invasive monitoring is where we should be heading towards.
So thank you. I have been asked to close the discussion. We are a little late. So thank you, Dr. Vassal, Dr. Budiwan, Dr. Mehta, Dr. Chawla and Kapil for this, and Diksha for joining us on this stage. Thank you.